a pioneer woman in neurosurgery. All the leaders. She decided to go for neurosurgery since she was 3, I think. 6 years old. And we are fortunate because her father is one of the mentors of neurosurgery in Jordan. And she will be a kind contributor to neurosurgery hopefully in the next few years. Dr. Aseel, thank you.
Thank you. Basically, اللي بدي أحكيه is directed to the general doctor, so it's not really into details. There's some points that could be missed or some misconceptions that I would like to correct. Let's start. وطبعا شكرا لدكتورة ميسم ودكتورة حنان على الدعوة. I really appreciate it. Let's start. لما بنحكي عن brain hemorrhage, basically we're talking about 4 entities اللي هم subdural hematoma, extradural hematoma, intraparenchymal hematoma, and subarachnoid hemorrhage. We start with the extradural hematoma. The classical teaching is it's basically a frontal or a temporal location. It's material in source. It usually happens after trauma. It's biconvex in shape, and it's associated with an overlying fracture. We have a lucid interval in patients, and usually it's managed surgically. Now we'll see that this doesn't really apply all the time. So this is the classical way that an extradural hematoma looks. So at the bottom, at the up left, we have a temporal location. And this is the biconvex shape. So this applies. And here we have a frontal extradural hematoma with an overlying fracture in the orbital roof extending into the frontal sinus. So this is very classical of the extradural. Here, we see an extradural hematoma with no overlying fracture. So this can happen, especially in younger patients where the skull can be moldable. So this can happen, so we have to keep this in mind. And this is a very scary, I think, CT for anyone on call. This is an extradural hematoma due to a superior sagittal sinus bleeding, so it's a venous bleeding. If you're on call and you see this, you call the most senior person. They have to come, and this is managed by the most senior doctor there. It's very life-threatening. Superior sagittal sinus injury can have many complications. Most of them are deadly, so this should be managed by a senior staff. And basically, sometimes when it's smaller in size and the patient has no symptoms or minimal symptoms, we can wait and it can be managed conservatively. So this goes against what we know as a classic teaching that each extradural hematoma is managed surgically. This is another one from a transverse sinus injury. Again, this is scary, call your senior. Now we have this extradural hematoma after evacuation of a subdural hematoma. So again, this can happen. The patient may not wake up after anesthesia. And this shows that each case should be managed with care. Each step should be managed with care. Usually, when we're done with the evacuation, we rush to do our closures, but we have to have meticulous hemostasis not to end up with this. And this is a paper talking about extradural hematoma after a lumbar puncture. Usually, we know that subdural hematoma can happen after LP, but this is a case of an extradural hematoma. So imagine your patient going for a lumbar puncture for CSF analysis or something, and they end up with this. So each medical procedure should be handled with care, even in LP. And this is what we've been talking about, conservative management of extradural hematoma. This is a brain CT of a patient who presented with an extradural hematoma, and they have an overlying fracture, and they have a subgaleal hematoma. So this was a small size extradural hematoma, and they decided to manage it conservatively. A few hours later, they did this brain CT, and we can see that the hematoma has evacuated itself into the subgaleal space. So this is a case of a spontaneous evacuation of an extradural hematoma, which can happen. This leads us to the criteria of managing an extradural hematoma conservatively. We have this. It's basically depends on the volume, on the midline shift, on the clinical status of the patient. So we have to keep it in mind, but usually if it's big in size, we have to go surgically. Now we'll go to the subdural hematoma. Again, this is the classical way a subdural hematoma looks like. This is a bilateral chronic subdural hematoma on the up left. We have a subacute hematoma up right. We have bilateral acute on top of chronic. So this is how it usually looks like. It's crescent in shape. It usually happens in old age. This is what we have in our mind. And we know that basically we would look for a trivial trauma history, may not find it. And this is usually treated surgically with burr holes. So when we're on call and we call the anesthesia on call, we tell them we have a subdural. They're like excited, it's a burr hole. Sometimes it's not. And this is how it looks like on the MRI. And let's please keep this in mind, especially this bottom right picture. We see these membranes. Let's keep this in mind because sometimes a subdural hematoma is not very simple. Again, this is MRI for the subdural hematoma. Please let's look at how it looks like on the MRI. It's not very simple. So again, let's beat the classic teaching. These are images of subdural hematomas in young children. If we see a subdural hematoma, if it's bilateral in a young child, please suspect child abuse. We think it doesn't happen in our country. It does, unfortunately, as it happens in other countries. So please let's keep this in mind. If we see a subdural hematoma bilateral in a young patient, look for other signs of child abuse and please report it. And let's not forget the entity, the very life-threatening entity, the acute subdural hematoma. An acute subdural hematoma may not be big in size, but the underlying brain injury is what's important. There's usually a massive brain edema underlying this hematoma. So this needs to be evacuated immediately. And these usually have a poor prognosis, poorer than extradural hematoma, unlike what some of us may think. Now let's go to the crescent shape. This is a brain CT of a biconvex bilateral collection, what looks like a collection. They went in thinking it's an extradural hematoma, only to open the bone flap and see that there's no blood underneath. So this was a bilateral subdural hematoma due to a superior sagittal sinus injury. And when I told you to keep in mind the membranes, because not each subdural can be managed with a burr hole, because if we have an organization of the membrane, we can end up having this look on the bottom left. We have a membrane that's fibrous. It has to be opened. The contents should be evacuated, and this cannot be done with a burr hole. So we have a big craniotomy for this patient. Another entity is conservative management of subdural hematoma. Again, depends on the volume, on the midline shift, on the clinical status of the patient. And usually these old patients, they have comorbidities. They have a high risk for anesthesia. They take aspirin, they take anticoagulants. They can be high risk for to be surgically managed. So sometimes we do manage them conservatively with observation, with steroids, with TXA, based on on what your hospital does, basically. And let's not forget that an aneurysm can present with a subdural hematoma if it ruptures. So we have here an MCA aneurysm that has ruptured into the subdural space, causing intraparenchymal and subdural hematoma, and we can see it extending even into the ventricle. So it's not just trauma. It can happen due to an aneurysm rupture. And again, another subdural hematoma due to an LP. Here it was due to an epidural anesthesia. So please, let's be careful. We're done with the subdural. Let's go to the subarachnoid. And we have the big categories, the traumatic subarachnoid and the aneurysmal subarachnoid. A traumatic subarachnoid would present with other signs of trauma. The patient would come with a history of trauma. We would have other, especially if the blood extends into the ventricles, it can cause hydrocephalus and the patient could die from this. Lastly, the intracerebral hematoma. The very famous hypertensive intracerebral hematoma, and it has a classic location in the basal ganglia. So when we see an intracerebral hematoma, we should keep in mind the location of this hematoma. We should know, and we should expect the pathology behind it using the location. So if it's not in the basal ganglia, if it's not in the cerebellar hemisphere, it could be due to another cause other than hypertension. Like this is a traumatic intracerebral hematoma. It's not a classic location for a hypertensive bleed. And again, if it's trauma, there are other signs and symptoms of trauma with the patient and on the imaging. This is an intracerebral hematoma after ABM rupture. So also the location can tell us the pathology underlying. Intracerebral hematoma after an MCA rupture. These are different MCAs on different locations. It could be an hemorrhagic infarct, it could be a venous infarct. Again, the location here is very important, it's fundamental. It can be due to superior circumstance thrombosis also. So we have mentioned this a couple of times. It could be due to amyloid and angiopathy. Again, the location and the process and the patient, the history, the physical exam can tell us the underlying pathology. It can be due to an infection. And I had a patient who had a diffuse fungal infection who died due to an EVD insertion because of massive intracerebral hematoma post-EVD. An EVD is a very routine procedure that is done every day, and patients shouldn't die because of an EVD, but that young girl had a very advanced fungal infection, and due to this EVD, she died because of the intracerebral hematoma. Drug abuse, basically amphetamines and sympathomimetics that can raise the pressure. And let's not forget a very important entity, hemorrhage into a tumor. There are tumors that can have hemorrhage inside of them, especially if they are metastatic tumors. The very famous ones are melanoma. We had a case just yesterday, massive tumor with massive edema, and it was all bleeding into a tumor. Turned out to be a metastatic melanoma. So let's keep our minds open to all of these possibilities. And my last message to you is to keep these challenges in mind when we deal with these patients. So if we have a trauma patient, we have to address the other injuries, and we have to address the most life-threatening ones. In older patients, they have comorbidities, they usually take anticoagulants, antiplatelets, and we have to know how to address a patient who has all of these complications in an acute setting. So if we have a life-threatening bleed and the patient is on antiplatelets, we have to go for surgery, but we have to know how to do it. You have to know the gray zone patients. Some patients can be clearly managed surgically and can be clearly managed conservatively. There's an area for patients in between. So these cases are decided on case-to-case basis according to a lot of things. Social is not the least of them. And the last thing I want to say is to keep in mind these atypical presentations of common disorders when we deal with these patients. Thank you.
We'll keep the questions for the end of the session, sorry.